So my talk will be updating and visualizing Crohn's disease in 2023. So this is my disclosure. So learning objective for this talk will be described the burden and unmet need and management challenge associated with visualizing Crohn's disease, evaluate the most recent clinical data associated with the newer emerging therapies with the visualizing Crohn's disease, implement coordinated and patient-centered management strategies based on the most recent evidence and consensus-based guidelines. I will go through the definition of fossilizing disease, prevalence, epidemiology, clinical burden of disease, treatment goals, and ongoing challenge, recognition, treatment, and diagnosis and classification, current emerging therapies, strategies, available target and biological medication we have, monotherapy versus combo, emerging therapies and clinical trials, and strategies in coordinated and patient-centered care. So we'll start with the definition. Definition of fistulas, usually inflammation at near anus, including tags, fissures, fistulas, and abscess stenosis. Symptom usually pain, itching, bleeding, perianal discharges, and fecal incontinence. Treatment usually anti-TNF plus or minus immunomodulator agent plus or minus ketone insertion. Prevalence based on population-based cohort, the prevalence probably at 10 years of patients with Crohn's disease, at 4 years, 14%, reaching almost 19% at 10 years. Patient with the Crohn's disease and perianal disease presented at 12%. Those patients who has colitis, Crohn's colitis and proctitis, they have higher risk to develop perianal disease. Most of them, almost two-thirds of them, they require minor surgery, either fistulotomy, ketone insertion, flap insertion, and other minor surgery. And only 6% they require a major surgery like proctology, like colostomy, proctotomy, and diversion ileostomy. The burden, how is the burden of perianal disease, perianal Crohn's in patients? If you look at it, we have burden of symptoms, including fatigue, restricted motility, discharges, pain, and they will have a negative impact on well-being. You will have patients with the perianal disease, absence of work because of this perianal discharges. Social, they will be more isolated other than normal population. Emotional consequences, you will have more depression on those patients. And physical restriction because of discharges and impact of this. And you have a burden of treatment as well. We have difficulties, and sometimes we know the most of treatment is a biologic. So accessing to the treatment sometimes will be difficult. Alhamdulillah, in Saudi here, we have no problem as Saudi to have most of medication. Probably in some center you have limitation, but most of medication are free, even biologic. However, you have in non-Saudi and non-insured patients, they will have difficulties to get this biological treatment, and we inform them in charity organization. Understanding and tolerating the treatment is also burden and side effect of medication as well. Treatment goal and challenges, suboptimal disease remission and outcome. So we'll try to define, know the anatomy of the perianal anatomy. So we have internal sphincter and external sphincter, and in between you have intersphincter space, and you have supraelevator space and isorectal space as well. So this is the perianal anatomy in general. Classification. So if we look for the BAL classification of perianal disease, most of patients or most of sphincter fistulas, it will come to the like intersphincteric fistula about 45%, 30% transsphincteric fistula, suprasphincteric about 20%, and only 5% extrasphincteric extrasphincteric fistulas. And 25% of patients, they have perianal disease, only 5% they have isolated perianal without any luminal symptoms. Another classification looks simple or complex. Simple is usually single tract, low below the dentate line, single internal or single external fistulas, opening, sorry. Complex is a multiple tract, high above the dentate line, multiple internal and external openings, anovaginal or rectovaginal fistulas associated with abscesses, structure, and recurrent. And most of the 70% of the Crohn's disease, they have complex fistula. A new classification it came to 2022 by AJA. This is classify patient into 4 classes based on disease prognosis, disease severity, and what you call it is a proactive approach between the surgical and medical to reach the target. So they classify, class 1 is minimal disease, minimal symptoms, and minimal anorectal disease burden. They require minimal control, minimal intervention of the time. And you have a class 2, which is defined, subgroup to class 2A and 2C, and 2B and 2C. Class 2A is repair. So you have a symptomatic fistula suitable for combined surgical and medical closure, either cetone and biological therapy. And you have 2B, which is you don't concern about. Is not suitable for surgical intervention, but you try to control the symptoms. So related to the fistulas, pain or discharges that improve quality of life. And you have class 2C. Class 2C, either you go with class 2C A or B, or 1 and 2. So early rapid progressive disease that dramatically progressive and destruct the perineum and you disturb the quality of life. In this situation, you cannot manage this patient with surgical or medical. You go with the defunctioning, meaning resting them by doing ileostomy. Class 2C2, which is gradually depleting, is not severely progressive, but gradually at the end, probably you end by defunctioning. Class 3, which is you need severe disease with exhausted perineum and with adverse features and end by proctectomy. And then class 4, which is 4A and 4B, these come after doing proctectomy. This is the new classification. I feel it looks like more details. It's not a simple. We didn't use it actually in clinical practice. So diagnosis, you diagnose fistulas based on examination, symptoms-wise examination, and you need imaging evaluation by MRI and examination under GA. So we'll go to the treatment, medical treatment of fistulizing Crohn's disease. So we'll go through gradually by moving on from antibiotic to biologic. So antibiotic here, Metro and Cipro widely used, but evidence is limited. Small randomized control trial of 25 patients was negative. Efficacy is combination with a biologic, Cipro plus infliximab or infliximab alone. First response as 18-week, it was 73 versus 40, which is not significant p-value. However, if you look for another study, Cipro plus adalimumab or versus adalimumab monotherapy, its response was significant at week 12 by 70% versus almost 47. So the role of antibiotic is as adjunctive treatment to decrease the drainage and improve quality of life. Immunomodulator, evidence is limited, primarily evaluating azathioprine 6-mercaptopurine and tacrolimus. Meta-analysis subgroup improved the fistula healing with azathioprine or 6-mercaptopurine versus placebo by 50% versus 20%. Tacrolimus, a high rate of fistula improvement with tacrolimus over placebo, but remission almost the same between placebo versus tacrolimus. What about biologic? So the only RCTs we have for it's for infliximab. So infliximab RCTs has shown being effective in closing fistulas. We know it's 5 milligram versus 10 milligram versus placebo, and patient with infliximab achieving almost more than 50% reduction in number of draining fistulae at 2 consecutive study visits. And if you look for perianal disease activity index improvement, there is improvement for at week 2 and week 18 significant p-value versus placebo. What about higher infliximab trough level? We heard about today in the morning by Prof. Rigero that probably you need a TDM and achieve more drug at fistulizing disease. So it's clearly here shown by the study, which is correlate between the fistula drug level, infliximab drug level and fistula response. So you need probably in fistulizing disease, you need more than drug on board in their body to achieve the clinical response and fistula closure. What about ketone plus infliximab? So here there is a clear evidence that combo therapy, ketone plus infliximab, improve the response, decrease the recurrence by significant p-value, and the time between the time to until you have recurrence, it takes more time if you have a combo therapy, meaning that ketone plus infliximab versus infliximab alone. What the optimal timing after starting ketone? So after putting ketone, so you have a patient that was seen by the GS, colorectal GS, and he put a ketone. So, and he referred back to you. So is it early or late or doesn't matter? So who will choose A, who will choose B, or who will choose C? Choose A, early. So B, okay. C does not matter. So most of the people, they said early. So we'll see the evidence. So this is retrospective analysis reviewing patient. Either you start early, defined early in this retrospective, defined early less than 6 weeks or more than 6 weeks. So early less than 6 weeks is 73%, 73 patients, and late more than 6 weeks is 44. And their primary endpoint was surgical reintervention. So if we look for the data, it was not significant. But if we look for the numbers, there is a trend toward if you do combination, early combination, it may reduce the number of surgical reintervention. So it's clearly here, though it's not significant, but it's a good sign that you start early, you prevent the reintervention or decrease the reintervention. Another study of 76 patients looked for recurrence of perianal fistulas. This is their primary endpoint, and secondary endpoint looking for clinical remission. There is meaning that there is no fistulas or partial response, decrease the number of fistulas more than 50%. And their definition of early, less than a month or more than a month. So early, less than a month by 49 patients, and long and late, more than a month, 27 patients. The p-value is not significant, but there is a trend also. If you start early, you may, the recurrence, the number of no recurrence is more than if you start late. And if you look for the secondary endpoint, which is induction, clinical remission at induction and maintenance, so there is a difference between the start early or start late, though the number is not significant, but the intervention, the complete recurrence and complete response and partial response is toward the early starting infliximab after ketone. So now we'll move on to the new biologic. So do we have now ustekinumab, new biologic ustekinumab? So there has been no RCTs looking for primary endpoint of their studies, looking for fistula response or fistula healing regarding ustekinumab. But from that, we have some post-hoc analysis from the trials that used in ustekinumab, Unity 1 and Unity 2 and Certify, and showed there is fistula resolution at week 8 is about 24%. So there is a improvement, and though the number is low, but we have a signal that ustekinumab, it may be good for fistula resolution. However, the fistula response as week 8, there is no significant p-value. Another retrospective cohort of 27 patients. They look for 6-month follow-up of they assess the perianal fistula improvement and 1 year. So there is in 27 patients, the perianal fistula improvement at 6 months about 48%, with 55 or 56% at 1 year, as well as there is improvement in symptomatic fistula, symptom of fistula. What about fidulizumab? Fidulizumab as well, has not been RCTs if addressing the primary or addressing the fistula response as a primary endpoint, but we have exploratory analysis from Gemini 2, published in Crohn's colitis 2018, and showed there is probably in 153 patients, the fistula closure is about 28% at week 14 and 30% at week 52. In systemic review and meta-analysis, in 4 studies in 198 patients, the response, the complete remission of the perianal fistulizing disease, almost 28%. We heard from Dr. Ahmed about enterprise study, which is RCTs. It's a double-blind phase 4 double-blind randomized trial, evaluating. Actually, if you look for the studies, the primary endpoint was not a fistula closure versus comparing the two regimen. They compare the two regimen, either you give extra dose as week 10 or continue the same regimen as standard, 0 to 6, and then you continue, or 0 to 6 and then 10, and then you continue. So there is a 50% reduction in number of draining fistulas at week 30 by almost 64% versus 42% at almost week 10. So there is no add value, and the fistula response was 42, almost 43%. So here they conclude either you add extra dose as week 10 or the continued regimen will be the same. What about new molecules or small molecules? Do you have data on supporting small molecules on fistulizing disease? So we don't have enough data. However, we have data on filgotinib, which is JAK1 inhibitor. It's phase 2 double-blind randomized studies, and this study was not completed because of recruitment issues because of COVID pandemic. However, we see the trend or see the number is going difference between the 200 filgotinib versus placebo at combined fistula response at week 24 and fistula remission at 24. So probably there's filgotinib could be a good options, or in the future, it's not now. So it was terminated, not completed. Do we need to use a combination to optimize the outcome on fistulizing Crohn's disease? So do we need to combine the antibiotic with the fistula, with the anti-TNF to optimize? So we have data from Adafi, published in GUT 2014 in 76 patients. After starting infliximab, start Cipro or versus placebo. Cipro was used for 12 weeks. And if we look for the response, is a good really with a big significant p-value at 12 weeks. However, if you look for week 24, either regard of reduction and 50% reduction or complete response, there is no difference at week 24. So you may add antibiotic as short term. So adding antibiotic to anti-TNF is more effective than anti-TNF alone in short-term fistula response, but is not in maintenance, in maintaining remission with the long term. Combined anti-TNF with the immunomodulator. Shall we use it or no? A, yes. B, no. C, I don't know. So who will go with A? Okay. Who will go with B? Most of us going with A. Okay. So the efficacy of immunomodulator of fistulas in healing has not been evaluated as a primary endpoint in RCTs. Data regarding utility of fibrin is derived from the subgroup analysis on RCTs. A meta-analysis showed no statistically difference in fistula response between fibrin monotherapy versus placebo. I'm talking about here for combo therapy. So this is a factors. This is a bold factors from retrospective evaluation. Looked for the factor that's associated with more of fistula closure. The combination of immunosuppressive plus infliximab is one of the key factors in for patients with a naive to the immunosuppressive, one of the key factors that has played a role in that associated with the response of fistula or fistula closure. Another one was negative, really. So a variable using azathioprine or mercaptopurine was negative to show any benefit of complete or partial response. So if you look for the guidelines, this is guidelines, Canadian guidelines, the advice to use when starting anti-TNF, we suggest combined azathioprine with a methotrexate or monotherapy, and this is low quality of evidence. If you look for ECHO guidelines in patients with Crohn's disease and complex perianal fistulas, there is insufficient evidence regarding the effectiveness of adding immunomodulator agent to anti-TNF. And if you look for the ACG, maybe effective and should be considered in treating fistulizing disease. AJA did not mention it. So it's up to you, but you have evidence supporting and evidence not supporting. Combination of dual biologic. Do we have good evidence on this? It was really bold analysis from retrospective cohort of 22 patients. At baseline, the 50% of patients they were present with fistulas. Post-treatment combination with dual therapies is 33%. So there is a trend that you maybe use it. I think I'm looking for the combination therapy and biologic. It could be in the future, near future. Is CETON required for long treatment or short? Because of time, so I will go through. CETON is showing that one of the factors, a key factor that play a role in closure of fistulas is CETON duration less than 34 weeks. So don't keep it for a long time. This is BISA study, randomized patient, either CETON insertion alone for a long time or surgical intervention or anti-TNF, and showing that if patient has long CETON, then you have more re-intervention. So think about using CETON for a short period of time. This is guidelines, or this is statement from the ECHO guidelines and European Society of Coloproctology. They advise to remove the CETON after induction of anti-TNF and sure that about resolution proctitis. Surgical management. Do you have time? So I will not go through in details about surgical management. So we have a CETON, we have flap, and we have another many surgical approach to approach it in fistulas. This is allogeneic stem cells transplant. It's been good, probably a potential therapies to use it in complex fistulizing disease. This is a real life data showing that clinical healing about 52%, with MRI also radiological healing about 52%. I will end by this, putting a diagram looking for management of fistulizing disease. Clinically suspected abscess, you should drain the abscess, drain the infection, treat the infection, And then you evaluate your patient. If you have a complex fistulas, then antibiotic ceton plus anti-TNF, continue TNF, consider TDM, as we mentioned it earlier in the morning, that it's be, and do proactive in this group of patients, and then optimize anti-TNF, and you evaluate your patient, keep harmony, and management plan should be clear, and then you consider another alternative. Thank you.